Hi, good morning, everyone. Welcome to the day 3 of the SMT Congress. So today, I'm very excited and honored to introduce our first keynote speaker, Dr. Carolyn Meltzer. So Dr. Meltzer is a dean of Keck School of Medicine of USC, and she's actually the first female dean to lead this, the oldest medical school in Southern California. She actually, in fact, that she just started actually this month. So prior to coming to USC, she was a chair of a radiology department at the Emory University in Atlanta. And she is a very accomplished neuroradiologist. She won actually numerous academic awards, that's including Outstanding Research Award and Gold Medal Award from ASNR, or American Society of Neuroradiology. And she served numerous professionals and board positions, that's including the member of board member of RSNA. She's also a very passionate advocate to advance careers in medicine and science for women. And she's going to talk about the title of her talk will be that technology advancement in healthcare, biases, and cautionary tales. So Dr. Meltzer, the floor is yours.
Hi, I'm Carolyn Meltzer. I'm delighted to be here to join you for this meeting and talk a little bit about technology and healthcare with a bent toward the brain, biases and cautionary tales. So disclosure, I have no financial disclosures, but I will disclose that I'm a neuroradiologist and we just love technology and new technologies. And there's so much in the brain space in this area, and functional neuroimaging, deep brain stimulation, bioneurofeedback, machine learning, AI, and even human cerebral organoids. I'm just going to touch on a few of these today. So neuroimaging has been used quite a bit, and there's very well documented evidence-based diagnostic spaces, but particularly in the functional area, it's been used beyond what is evidence-based. And I've looked a lot at medical legal issues, particularly in criminal culpability cases. So somebody acted in a criminal way, and brain imaging is then to show that they were not culpable because there's a fuzzy thing in this area of the brain, and that's especially been used in death penalty cases for sentence mitigation, and also in assessing brain maturity of juvenile offenders, which is a very interesting area. Of course, child abuse, which has evidence-based diagnostic capabilities, but also can be overused or misused in that space. Brain behavior relationships are complex, and imaging does not necessarily tell us exactly why someone has acted a certain way. And then sort of used in sham products and treatments, lie detectors. We have to remember that a lot of functional imaging can be used in highly representational ways, but these images are compelling. This one is on the cover of an album by Muse, a band I happen to really like, and I especially like because they have a brain, DTI image on the cover, but certainly difficult. This looks anatomical, but is really derived from functional data, and that's difficult for laypersons to understand, such as folks on a jury. We also see, products and services out there, such as the Ammon solution, using, in fact, brain SPECT imaging to overcome and change behaviors. And, I don't know that I can really tell the difference between a mass murderer after gratitude, before gratitude, but these images are compelling when they're shown to, especially the lay people, and when they've been processed, maybe compared with small and inappropriate samples of normal brains. I've been interested in machine learning for a long time. Before it was really AI, but sort of in the earlier days. I had colleagues I worked with in the brain behavior space, and they would kid me. They would say, gee, you know, you as a neuroradiologist would read this brain MRI as a normal brain. And this person, you know, has difficulty with navigating the world with a clinical diagnosis of schizophrenia. So that can be disheartening. So functional imaging has a role in really trying to get at these relationships, some in the research space, fewer applications in the evidence-based clinical diagnostic space. So I had worked with colleagues at Carnegie Mellon, the Robotics Institute, a number of years ago, and we looked at a large number of MRIs. We compared those with schizophrenia to the MRIs of, and these are again structural MRIs for subjects who had schizophrenia, and looked at, you know, thousands of variables to distinguish the groups. Some of these don't necessarily have direct physiologic meaning to us, but are sort of inherent in the images. And what we found was we were able to separate with this machine learning algorithm the brains of the schizophrenics versus the brains of the controls. And this held in, you know, a new, using that same algorithm in a new batch of subjects. And we never published it beyond a symposium, or conference proceeding, because it really struggled with what were these features. They seemed to be skewness and symmetry and things that were difficult to explain physiologically. Why was this algorithm able to separate and distinguish schizophrenic brains when I, as an expert neuroradiologist, could not? Now, artificial intelligence gives us even more capabilities in its current and evolving form, especially in radiology and medicine overall, in healthcare. And, you know, here's an example. This is a CT scan. In the interpeduncular cistern, there's a bright spot, just that triangular bright spot. And this is one slice out of many slices. And this is a classic example of something that can be easily missed, especially by a tired neuroradiologist at night or radiologist at night. And that's subarachnoid hemorrhage, indicative and very highly indicative of an aneurysm rupture. You know, we've all missed that little dot at times. So there are programs that can look over the image with AI algorithms and point it out and say, hey, look here a little more closely. So while I don't believe that AI is going to take over the role of radiologists, pathologists, engineers, those professionals who can use the augmented information from AI will be in a better position than professionals who cannot. We also have substantial physician shortages, and especially in some areas of specialty. So with the demands for patient care, we do need augmented tools. So these are going to be important. What I've been very interested in is how do biases get translated into AI algorithms and other technologies. So we have systemic and structural biases in our healthcare systems, in our training, in some of the clinical information that we've been taught. But and there's also statistical bias. So statistical bias when a lot of our sample sizes are maybe large for clinical trials databases, for genomic databases, but we know that these tend to have underrepresentation of subjects who are traditionally underrepresented or marginalized or underserved communities. And that can lead to bias of the results and sort of a difficulty applying AI algorithms developed from these databases to populations that are diverse. And the social bias is how are we also translating the inequities in our healthcare system and our systemic and structural biases into the algorithms. So we know that health disparities are a huge issue for our country, and health disparities start in children. It's not surprising. We see it throughout the lifespan. In 2010, the American Academy of Pediatrics published a landmark report highlighting extensive, pervasive, and persistent disparities in pediatric healthcare delivery and quality. We know images are key to diagnostics and certainly thus to health equity with providing appropriate and prompt diagnosis, monitoring treatment, non-invasive therapies. And what was found in this very large study of 44 children's hospitals and over 13 million visits was nearly a third of visits included imaging studies, and not surprisingly, but the percent of white children who received imaging was higher than those for non-Hispanic Black children or Hispanic children. And this significance persisted across imaging modalities and when stratified for insurance types. And they continue. So this is a study from my prior institution where pediatric patients who had undergone a liver transplantation over a long period were reviewed in terms of their care as they progressed into adult care. And of the 100 that met the inclusion criteria that transferred into adult care, 28% of them had subsequently died. That death rate was considerably higher in African American or Black patients as opposed to those who self-identified as white. So certainly quite concerning. This is an adult study looking at emergency department medical imaging studies, also showing disparities in who received imaging. And in this study, showing that advanced imaging, CT and MRI, was more likely to be used in white patients rather than those of who identified as a Black or African American or Hispanic Latina. And our biases in medicine are also individual and social. And this is a rather painful study that was published in 2016, where actors were playing families and a patient and the patient's family. And the scenario was that physicians were to come in and to tell the patient and family of a poor, dismal diagnosis. So these were real physicians. Experienced physicians tend to have a script for doing this. They've developed over time. It's a difficult task. And what they found were the physicians, whether they were dealing with the actor families as white or non-white, they had a similar verbal script, but white physicians were less likely to touch or make eye contact with non-white patients and more likely to stand by the door. And we know that touch, eye contact are really important to build trust with a patient. So not the same experience. We also still to this day have structural biases encoded in medical algorithms that are race-based. Heart failure risk, the glomerular filtration rate, and a lot of hospital systems are now taking that algorithm out, that race-based algorithm that's used for things like determining eligibility for kidney transplantation. There are algorithms used for vaginal birth after cesarean with predicting a lower chance of success in Black and Hispanic patients, which may be sort of circular logic because the lower chance of success may be due to inequitable care. So we have to really be conscious of these really built-in structural biases in medicine and how we translate them. There's also, when we look across life as well as healthcare, there tend to be an absence of, in particular, gender segregated and representative gender parity in data. So a lot of design is around for offices, for transportation systems are designed around a standard default man and behaviors more commonly of men in our society rather than women. Cars are designed around the body of a reference man, which is why at my height of 5'2", I drive a Mini Cooper. It's the closest thing to fitting me more comfortably. Most crash test dummies have been modeled on men's anatomy, and thus women are more likely to be seriously injured in a car accident. And that is certainly concerning. So data is not data is not data. It needs to be examined for representative diversity and also looked at to see if there are differential impacts and design issues. Of course, there's been a lot of discussion around patient privacy with technology, particularly imaging technology and AI algorithms. Electronic health records don't cross health systems very easily. They should, but often, we sort of have data sent in different ways that are potentially more likely to be exposed to providing patient information that should not be disclosed. Health information companies are accessing big data, buying anonymized patient data. How anonymous are some of the data? Is it really anonymized if you have the raw data from a brain MRI that includes the face, and the face could be reconstructed? Rare patients presenting with rare disease scanned on a specific date can probably be tracked through multiple data sources to identify that patient. And we haven't quite figured out how patients consent in these situations. Taking care of populations when we apply AI, there have been studies that show that algorithms developed to try to guide risk of patients to then follow through a care coordination program. These somewhat black box systems, when we enter, are a large number of a large data set, and it built in are inequitable outcomes. Here, in this case, at the same level of algorithm predicted risks, the Black patients had more disease burden, but were not defaulted into the program at the same rate. So again, things to watch. My prior colleagues at Emory had looked at medical images entered into an AI algorithm stripped of header data, and found that the AI system could evaluate self-reported race data in ways that impacted the patient diagnosis, treatment course, or outcomes, and in ways we didn't quite understand. What about education, workforce training? As we talked about it, I don't think, despite dire predictions, I don't think the end is near for radiologists, pathologists, and others, but the ability to use AI tools is going to be critical going forward. One other risk we have to be wary of is that when we implement clinical decision-making tools, such as plugging in a patient's information and having pop out a medication dose or a suggestion of diagnosis, that there is the human tendency to be subject to automation bias and to say, well, if the algorithm showed it, it must be so, and not do the harder work of discerning whether there is a chance for error. So we have to augment our skill set with AI, with tools, technology tools, but not give up our brain to them. So thank you so much for allowing me to share these thoughts. I'll leave you with this quote by Marie Curie: "One never notices what has been done, one can only see what remains to be done." Lots more work to be done, a very exciting field. Thank you so much.
Okay, thank you very much, Dr. Meltzer, for talking very important issues in medicine in general. We appreciate it. So for the audience, do you have any questions or comments? Oh, yes. So I think there's a microscope over there. Yes. So we have it's over there. Yes. Okay, so we have one audience who has a question.
Thank you. That was a wonderful talk. I'm curious about what are some of, as a neuroradiologist, do you anticipate the medical legal implications of AI and how that's going to intersect with us as physicians? And will we be in a position in a decade from now where we have to take back or retract what we had taught the machine?
Oh, I'm sorry, I think it is mute. Can you? Okay. Oh, Dr. Meltzer? Oh, yes, now we can hear.
Oh, okay.
Thank you.
As usual, technology tends to advance ahead of medical legal analysis and legislation. So there's a lot of discussion nationally, internationally about the ethics and guidelines of the use of AI. But we don't really know where we're going to end up in terms of medical legal risk. What if an AI system tells you, suggests a diagnosis that doesn't turn out to be so, but you've relied on it, and an expert comes in, looks at the images, and says, "Oh, well, anyone with this training would know that wouldn't be a likely diagnosis." I also worry a lot about the patient privacy issues. That's why I had stuck in an image of Henrietta Lacks. As many of you know, her cancer was the origin of HeLa cells that were monetized and used for experiments throughout the world without her consent. And certainly we've had a very thorough look at that with historical lens. As we give patient data to AI companies, is there a consent process there? Is there a privacy issue, as I mentioned? So I think there's lots to be considered and concerned about. These are exciting tools. Just it is time to certainly pause and think of the risks to the patient and to the process. Thank you.
So any more question for her? Okay, so there's another.
Congratulations on your appointment, and very excited that you can be involved. I just had a question about big data. This is really going to drive the system in the future, with genetics connected to radiology. In eye care, it's actually scans of the retina will also be a part of this huge mix. So we got blood tests, and then this, obviously the power of personalized medicine will enjoy. But again, this idea of whose data is it, and can this data be used to drive the whole system to make it better? Because now we will have this opportunity to have this cross-section of the diversity of our population, and not only the United States, of the world. So that interface is sort of exciting. I guess I'm not leading to a question very well, but more of a comment. But who is going to be drawing these boundaries? I guess the question, is it going to be in the academic stage part? Is it going to be in the the private sector, or is it going to be government? Who's going to drive the ship?
Yeah. I think there's a wonderful guideline paper, Europe and North America, that looks at these issues critically and also looks at differing status of who owns the images, the blood work, is it the patient, is the hospital, and that can vary from country to country. So there's been a thoughtful approach to this. If we don't drive it as caregivers and professionals and researchers, government will come in. They may come in anyway, but we have to guide the process so we can, as you mentioned, it's of great benefit to population health that we use these big data tools, but we also have to do so carefully and put some guidelines in place.
Any more questions or comments for Dr. Meltzer? Okay, that's fine. Okay, thank you. Thank you very much for taking a busy time to participate in our Congress and cover the most important topics in the recent.
Thank you so much, and congratulations on a wonderful conference.
Thank you. Okay, so I would like to announce the next keynote speaker. She's Dr. Keyne Johnson. She is a board-certified pediatric neurosurgeon, and she's also an accomplished fellow of American Association of Neurological Surgeons, and she's also assistant professor of the University of Central Florida School of Medicine. So her title of her talk will be the Future of Spine Disorders and Innovations.
Good morning, everyone. Thanks for being here so bright and early. I know we had the gala last night, and so I appreciate you waking up despite that and coming out. So again, I am Keyne Johnson. I have my own private practice in Orlando, Florida. And although it does say Brain and Spine Institute for Children, I also operate on adults. I do adult spine as well. And, in thinking about where I started, when I started, actually, ironically enough, one of the neurosurgeons who kind of mentored me when I was in medical school was sitting at my table last night, Dr. Maroon, Joe Maroon. So I thought that was just, yeah. But in thinking about even where the technology that was available and the things that we did and how we treated different spine disorders, different spine problems, even from medical school to now, has drastically changed. And so I'm just going to go through some of those changes, some of the things that are happening now that we're looking at happening for the future, and some of the amazing innovations that are taking place. So as far as disclosures, really quick, I am on the Globus Medical Surgical Design team, and I'm also an orthofix consultant. So surgery of the past. So we know about the Edwin Smith surgical papyrus, that kind of gave us the first known references to spinal disorders from ancient Egypt. And at that time, they used to say that someone had a spinal fracture if they had any loss of feeling in their legs or arms or any type of paralysis. They just said their spine was fractured. There is some evidence that they did find in mummies who had spinal surgery all the way back from 3000 BC. And the first laminectomy was thought to be performed in 650 AD. So we've been doing spine surgery longer than I think we actually thought we had been doing it. So in the 19th century, they started doing a little bit more laminectomies. However, the outcomes were fairly poor. It was a high morbidity, mortality rate. For a few reasons, right? We didn't have the same anesthetics, if any anesthetic. Infection, right? We probably didn't have the best sterile techniques. We, talk about masks. If you look at some of the old pictures of surgeons operating, they didn't always have masks. So I would say masks work, yeah. But, and also just gloves and how to, treat the wound and closures and things that we now don't even think about. It's just like second nature. I don't even, those are things that they didn't have accessible, probably, but also, again, just, knowledge, it makes a huge difference. So the other thing that looking at surgeries today versus surgeries back then, even simple things like a simple laminectomy or discectomy, these patients stay in the hospital for long periods of time, whereas now they will leave the same day. And, we're talking maybe an hour or two of recovery and they're home. So that's a huge difference versus a whole week is what they would typically stay in the hospital prior to that. So 1885 was the invention of the X-ray. And you can imagine, that was probably life-changing for these surgeons to know now. They know where they're actually going. They can see the anatomy. And I'm sure this to them was probably like intraoperative CT and robotics for me. And so it allowed them to have less morbidity, knowing exactly the anatomy and where they're going and being able to navigate a lot better and better outcomes for the patient. So as we develop in technology, as things begin to change, we also see not only is it easier for the surgeon, but it's also better for the patient and better outcomes for the patients. And again, in the early 1900s, there's actually evidence that we were doing spinal fusions and treatments of scoliosis actually emerged. Now, we'll talk a little bit about the difference between the instrumentation kind of used then and used now, but still, they were treating patients who had diseases that probably, would have caused them possibly to be paralyzed or not able to fulfill their lifestyles. In 1932, Mixer and Barr performed the first discectomy. And in 1975, Dr. Hijikata removed a disc through a tube. So he did a discectomy, but he said, you know what? So I can imagine, back then, incisions were a lot larger than they were now. So for a one-level discectomy, you were talking, an incision could be probably, about this long, right? Whereas now it's probably about this long to do a discectomy, and maybe even smaller. And I'll talk about that later. But Dr. Hijikata removed a disc through a tube. And when you talk about doing minimally invasive surgery, it's less tissue disruption, right? You're not having to damage the structures around it. It's a shorter recovery time for the patient. So all the things that are, again, you're talking about benefits. However, it wasn't exactly totally accepted and adopted, and we'll talk about that. But in 1977, Dr. Kaspar and Yassergil started operating through the microscope. So again, this gives better visualization. So we've gone from not having really any visualization to now we have a microscope so you can see fine details and the surgery can be more precise. Again, better for the patient. You see where I'm going? All this is about the patient, right? Patient first. So. In 1990 was the introduction of the laser. Again, it was introduced. It doesn't mean it was necessarily accepted, and I'll get into that. So now we see in 1990, they developed this tubular retraction system, and now it's gaining this popularity. But remember, in 1975, Dr. Hijikata had already operated through this tube, but it wasn't accepted. It wasn't, and more than likely, people probably poo-pooed it and thought, this is crazy, who's gonna operate through a tube? You can't see through a tube. You need total visualization, you need big incisions, big exposure in order to see better. Bigger doesn't always mean better. So, again, it wasn't initially accepted, but 15 years later, I think whoever saw this was probably like, wow, this works. It's better for the patient. There's more benefits than risks. And it started to become popular, and people started to do it. And so when we talk about also doing things through the tube, we're able now we put screws. We do that as well, minimally invasive, even putting screws in. I put this next picture beside that one is a picture of Dr. Ara. Oh, thank you. Did I sound dry? Okay, thank you. It's Dr. Ara Duke Medjian, and he gave a talk on Thursday. And I was just so impressed by not only, of course, what he's doing at his Duke Spine Center in Florida, but more importantly, that he didn't stop just because someone told him that's not going to work, or that's crazy, or, he actually said he had daggers in his back, essentially. And the surgeries that he's performing are laser surgeries, laser discectomies, even anterior, so anterior cervical discectomies through a tube with a laser. It sounds crazy, and I'm sure he was called crazy, and people called him dangerous. But a lot of the things, even a lot of things we heard about even last night at the gala, and a lot of the innovations, and you saw those patients that came up whose lives were completely changed. If someone had stopped, and just because someone else said that's crazy, or are you nuts? It's not going to work, or it's too risky, then who knows? Those patients' lives could completely have been changed for the worse, or they may not have even been up there. So I really, admire him for that. But I can imagine Dr. Hijikata probably going through that same thing when he did his first surgery through the tube, and now it's popular. So, the same thing with Dr. Ara doing these discectomies, right? Laser discectomies. And impressively enough, he said that he's done 600 without any adverse outcomes. And that's amazing. But what's more amazing is you hear the patients, they left the hospital the same day. They were back at work 3 days later. Their pain was gone that next day. So again, faster recovery time, shorter hospital stays, smaller incisions. His incision, you only need to cover it with a Band-Aid. Improved pain relief, and again, fewer neurological deficits. So I'm going to play this this video that kind of speaks about what I'm.
Tonight for your health, a possible cure for back pain sufferers without major surgery. Dr. Bruce is live tonight in Santa Monica with the exclusive details. Dr. Bruce.
Michelle, I'm at Robert Forster Physical Therapy in Santa Monica. They train and take care of Olympic athletes and weekend warriors here. Now, 4 out of 5 Americans suffer from back pain at one point or another, and this may be the simplest surgical solution yet.
Let me look at your back.
Mitchell Scott's back has been hurting for 20 years. It got really bad last fall after some heavy lifting while gardening.
It started out with a twinge right next to my tailbone, and it just progressed and got worse, and every day it got a little worse.
MRI showed that Mitchell had 2 herniated discs.
You can see how this is pushing out.
Medicines and physical therapy failed to help, but Mitchell did not want major surgery. So he turned to the internet, where he found Dr. David Ditzworth's website, which offered an alternative.
It looked like a great way to treat a herniated disc.
Ditzworth calls his approach small endoscopic discectomy. He simply removes pieces of the herniated discs through a tiny scope.
It's a procedure that requires precise planning and mapping to come exactly to the spot that needs to be treated in the spine.
That planning begins with a test called the discogram. After numbing the area, Dr. Ditzworth injects dye right into the bad disc. A CAT scan then shows him the exact route he has to follow with the scope to cure the problem. The next day, Mitchell went to surgery. He remained awake as the doctor numbed his back and made a very small incision, only about 0.2 of an inch. Using the CAT scan as a guide, the doctor inserted the scope and a tiny grasper, which he uses to remove disc fragments that are pressing on nerves. It took only 30 minutes to treat the first disc. The second disc took even less time. With only a bandage covering the incision, Mitchell was able to leave the hospital a couple of hours later. Early the next morning,
I'm glad it worked out for you, Mitchell.
after spending the night with his parents in La Crescenta, Mitchell was ready to head back home to Templeton just in time for his daughter's soccer game.
It'd be hard for her to believe that I've had back surgery one day and come to her soccer game the next day. I feel great.
So that just shows where we've come, where we were, where we are now, and that the things that people may have thought were crazy, obviously patients have benefited greatly from. So now getting into image and navigation of the past. In 1973, Dr. Hounsfield produced the first CT images in a patient. And in 1977, the first MRI was performed on a human patient. So when you look at this machine, kind of archaic, and actually my 12-year-old son was looking and helping me with my slides, so I will credit him for the inserts of the videos, but he was like, I would never get in that thing. And now when you see, right, what our MRIs look like now, they're a lot less scary. You don't see all the metal and everything around them, but it took someone actually having the courage to say, okay, we can do this, so that we can see inside the human body a lot better. And because of this, obviously, we're able to do a lot more. And so in 1985, we had the 1.5 Tesla. So again, we're getting better and better images, right, to see soft tissue and the structures. And then in 1994, we had the first intraoperative MR at Women's Brigham and Children's Hospital in Boston. And again, just helping to navigate for the surgery, knowing where we are is all important, and again, important for the patient and for better outcomes. So this is actually looking at the 7T. This is a brain image showing the vessels, and to see the vessels that clearly. But even at looking at the spine, if you look at the one, it's like cut off. I don't know why that came out like that. But the first one that you see in A, that's actually on a 3T scan. And then B is the 70.5 millimeters. And then you see in C, it gets a lot clearer. And so, why would we need something that clear? Well, if you're thinking about diseases like multiple sclerosis, right, you want to be able to see those lesions clearly. Even in any other, really neurological disorder, tumors, vascular diseases, with the 7T, you can see the vessels, you can see even the dentate ligament, pia mater, dura mater. So it's really impressive, the things that not even for diagnosis, but also for treating a patient. So now, when we're looking at navigating through the spine, we're actually doing this with intraoperative CT. So we're able to put hardware in just with doing, so what you see in the first picture that's the intraoperative CT. So you put fiducials on the patient, and then a spin is done with the CT scan, and then we can use that CT scan to navigate exactly where the screws should go, where the hardware should go, which again, and it can be done in the lumbar, it can be done in the thoracic, and even cervical spine. And the accuracy is important, and it's important for patients, it's important for missing any neural structures, and so, we're looking at safety as well as accuracy. So one of the other things that we use is also the robot, and here I'm actually doing screw placement through the Excelsius GPS robot that we now have. So the robot has actually literally brought me over to the spot where the screw needs to go. So it's really impressive now what we're able to do just with the imaging and navigation and how far we've come with that. And it's a lot of fun, by the way. So when we're looking at imaging of the future, global technology, voice recognition, so being able to say, it's actually almost like Siri, hey Siri, put my screw in S1, those type of things. Dr. Metzler hit on the artificial intelligence. We'll go a little bit into that, and even VR. So when we talk about machine learning, artificial intelligence, just as we heard in our last talk, looking at a programming algorithm where a computer can be trained to perform various tasks based on data provided. And of course, right now, like you saw, we have AI-guided pedicle screw placement and even applications for surgical procedure for sagittal alignment, predicting patient outcomes, and even more. So this is a little bit about the VR, something that's recently been used in the last year.
This is our consent form for the procedure. As you know, the novel part about this procedure is we're going to be using a new augmented reality guided computer system that's mounted on a headset so that we can accurately place the screws into your back.
I'm Kay Bartulis. I was diagnosed with spinal stenosis. Dr. Witham, being the expert he is, was the one who took the case and corrected my problem. I was having horrible muscle cramping, like twisting. It would hurt so much, even at the mall. The lower back pain would be so much I just didn't want to keep going. I'd have to find something to hold on to.
It was hard to watch. We felt like someone was going to help her, but knowing she was with Dr. Witham, we knew she was in good hands.
We are extremely excited to be doing the first ever in the world, really, augmented reality guided procedure for placement of spinal instrumentation in one of my patients. She has a common condition in the lumbar spine called spondylolisthesis, which is a slippage of one vertebra relative to the other. And that causes radiating pain down the leg, or sciatic pain that people are familiar with. A lot of times we'll try to treat these things without surgery, but when the non-surgical treatments fail, that's when surgery comes in and can often be very effective.
Probably needs to go a little bit closer.
They were all so sweet and talking to me, you're going to be fine, and they were getting ready to get all this stuff hooked up on me, and actually it made me feel a lot better because it was almost fun watching them getting themselves prepped. Dr. Witham was getting his headset put on, and they were making sure that everything was working with it. And then after that, I got whatever they put me out with, and I was gone. Goodbye, Kay.
This is an amazing technology that was developed based on the type of headset that fighter pilots commonly use. But there is also a computer onlay that shows us not only the surface anatomy of the body, but also the internal structure of the bone in 2 planes, which is critical in terms of our directing a screw, let's say, into the bone in the spine. By having all of that information right in front of you where you can attend to the patient and view the computerized images to show where you're directing that instrumentation, it's a game changer.
I'd never worried about his technology with that. I was actually very happy that they had it. And I said, well, all I can say is anything that would allow you to have better vision inside my body has to be a benefit.
This makes it more seamless and easier, I think more efficient, and I think it's going to be more effective and accurate for patient care. And it's going to make what we do, I think, better with better outcomes, more efficiency, better accuracy of placement of spinal instrumentation.
So again, back to why we do what we do, right? For the patient, to make them better and easy. But we as surgeons like to have, as the doctor said, seamless, for things to be seamless and easy for us as well. So just gonna wrap it up here with a little bit about spinal hardware of the past. So this was Dr. Gailey in 1940 who came up with this technique for fusing C1, C2. And it was a wire technique. So there weren't any screws, it was wired, bone was placed in kind of an H-like fashion and tied around. And then Dr. Brooks actually modified it in 1978, where he put the piece in between the spinous processes. But now we have pedicle screws and translaminar screws for C1-2 fusion. We also, not just for fusion, but we realize, well, maybe fusing a patient isn't the best thing. Maybe, limiting their motion and taking away their degree of mobility isn't what's best for the patient. And so someone came up with the bright idea of doing a disc arthroplasty. Let's put something in there that mimics our natural disc, where it gives the patient the same degrees of motion. We also showed in studies that when you fuse a level, that the adjacent level can actually have disease process, or you're putting more axial load on that level above and level below, and those discs can then in turn herniate out. So we came up with the artificial disc, and this particular disc is one that I use quite often. It's actually the only one I use now. It's the M6C artificial disc, and that's for cervical herniated discs, and it's placed anteriorly. And again, it allows for patients to have, it acts as their own natural disc, so they don't lose any motion. And again, we're talking about patients' outcomes, their lifestyles. Again, they get back to work sooner, they recover faster, and they don't have to stay in the hospital. This is an outpatient procedure. So we're continuing to progress. So now what are we doing? What's the future look like for hardware, instrumentation? We're actually 3D printing hardware. And this allows for patient specificity, right? For it to be patient specific, bone specific, defects specific. So at this point, we're only 3D printing that I know of right now, implants for fusion. So this would be for a T-lift. However, looking at the future, why not 3D print for artificial discs, right? For disc replacements. You're talking about that specific implant is specific for that patient's anatomy, and that's where we need to go, because everyone is different, and you hear that all the time. Everyone's body is different. Everyone's bone structure is different. It's really true. I've literally seen it. So, I have one patient that may have small vertebrae, another patient that may have larger vertebrae. So it's great if we can specifically make an implant for that patient. And when you look around or look at turnaround time, typically for this, it's going to be about 10 hours or so to kind of crank out this 3D implant. But, again, with technology, we can have it faster. The goal should be, even in a trauma setting, a patient comes into the ER, they have a traumatic disc herniation or something where you have to take them to the operating room. Hopefully we can have the 3D printing right there. It can be made within a couple hours. I mean, that's technology, that's innovation, right? So I don't think I have time to play this one, but basically it's talking about nanotechnology for spinal cord injury. And again, with nanotechnology, again, for the future, it enables the creation of novel diagnostic and therapeutic devices on matter at atomic or subcellular levels. So when we're even thinking about, spinal infection, things that we're already currently doing for spinal infection prophylaxis, we're coating the actual screw with a silver nanoparticles. And this reduces the formation of biofilms and hopefully help in curtailing things like MRSA. So again, nanotechnology is something that's in the future and that we're actually using and putting to use, even delivering drugs to nervous system, again, helping with spinal cord injury and paralysis. So I would be remiss if I didn't put these last two slides and then I'm done, given that it's Women's History Month. So when we look at spine surgery of the past, these are some of our pioneers of spine surgery, and now spine surgery of the present and future. And these are all my ladies we all graduated from Duke residency program. Amy Heimberger was my chief resident, and I was Dr. Reynolds' chief resident. So we are in the future and the present. Thank you. I guess it would be, so would your question be, would we still do the wiring technique? So actually, yes, there are times we do have to go back to the past. Interestingly enough, I had a young boy, I think he was maybe 4 years old, and he had he fell at daycare and ended up having and he had an ostodontoid. Long story short, he needed to be fused to C1-2, but he barely had a C, it's all cartilage, right? So I did have to go back to the old school wiring. There weren't any, I didn't have a lamina to put translaminar screws in. There were no screws big enough for him. Now, what we could say is, well, maybe if we could, if I could have 3D printed something specifically for whatever bone he had there, that maybe I could have put something in there for him. But from what we have currently, no, I had to go back to I sort of used almost like a wire kind of technique to pull the vertebrae together. But yeah, great question. Not really. I think, we always had pedicle screws. If you're talking about like fusions, those kind of things, Yeah, for the most part, we still are able to use the newer technology. Yeah. Correct. Yep. Agreed. Other questions?
Great presentation, Dr. Johnson. And I'm glad you have a great family tech team, too. They did a great job. It was all flawless.
Nothing like a 12-year-old. No, way more than me.
Yeah, you look
Yes.
for your tech people. I just wanted you, would you ever address the structure versus symptom issue? In other words, you look at a back, radiology, and it's got all these problems, yet no symptoms. And so it seems like the diagnosis is driven only by symptom in a lot of cases. And yet the structure looks horrible in some cases. Are there any inroads based on, improving that structure to symptom sort of dichotomy that's the problem?
Yeah, so, and I think it depends. That's a great question. Thank you. I think it depends on exactly where we're talking about, right? So if I see someone come in, as you say, asymptomatic, and let's say maybe it was after an accident, and I see that their spinal cord is compressed, and I see T2 signaling in their spinal cord, then despite the fact that they're asymptomatic right now, my conversation with them is a lot different. So, of course, you can't force a patient to have surgery, right? But what I tell them is, based on everything I know, based on what I see, based on your radiographic imaging, your chances of becoming paralyzed if you were just to fall or possibly move the wrong way or manipulate your head the wrong way is pretty high. So in that instance, I would recommend doing surgery for that patient. But if they're asymptomatic, there's no, the spinal cord isn't flattened like a pancake, there's no T2 signaling, then you're right. I wouldn't recommend, and I'd say, okay, let's just watch you and follow you. So is there a way that we'll be able to predict possibly? I think it's again, putting this information into even the AI system and seeing, you have an asymptomatic patient, they have this disease process, what is the likelihood that they're going to progress to need surgery? And I think it's easy enough. We have enough patients, we have enough data, it's just all putting it into the same pool and cranking out that number. Well, thank you.
So yes, that was an excellent talk from Dr. Johnson and also Dr. Meltzer as well. So anyway, with this, we will conclude our morning session of a keynote series. And just one minor housekeeping matter. So from tomorrow, daylight saving time will begin. So we got the 1 hour of less sleep. So if your watch or your cell phones are not set as an automatic time change, then make sure to bring 1 hour forward from tomorrow. Okay, great. Thank you.